All right. Hello, good morning, good afternoon, good evening, whatever time you're tuned in or chosen to listen to me. I want to welcome you to today's lesson. My name is Violet Aswa Akek. I am a lecturer of pediatrics at the Kenya Medical Training College, Department of Clinical Medicine, Nairobi campus. Today we are going to be looking at the morphological features of acute inflammation. This is our second in several series that we shall be covering in the area of acute inflammation. So welcome. Before we delve into today's lesson, it is good to recap what we learned in lesson 1. Firstly, we looked at the definition of inflammation, and we said that inflammation is derived from a Latin word inflammare, which means to burn. We also said that inflammation is the normal physiologic response of normal healthy tissue to any type of injury or insult, irrespective of the type of injury or the cause of the insult. We also said that whenever a tissue is inflamed, its description will usually be accompanied by the suffix itis, and it will also be dependent or falling on a background of the cell type of that particular tissue. And we gave examples now, like for example, cardiac tissue, which is the heart muscle. Then if it is inflamed, it would be referred to as carditis. We also gave another example of like hepatitis from the hepatocytes, which are the cells that form the liver, and then the suffix itis, and therefore the word hepatitis as describing inflammation of the liver. We also gave a few exceptions where that does not always apply, and they included inflammation of the skin, where we do not say skinitis, but rather we say dermatitis. We do not say pleuritis, but we say pleurisy in case of the pleural tissue. We also looked at the purpose of inflammation, and we said its main purpose is to localize and also eliminate the causative agent, that is the agent that is causing the injury, also to limit tissue injury, and also to restore the tissue back to its normal structure and function. We also talked about the nature of inflammation, and we discovered that the nature and how inflammation takes place is like a stereotype. That means how it happens, how it starts, and how it progresses is the same in all tissues, and irrespective of what could be causing the particular injury. We also looked at the microcirculation, what happens under normal circumstances, and we compared that or looked at it against what happens when there is an acute inflammatory reaction or response. And so we looked at the nature of the structure of the microcirculation. And remember, we said that the microcirculation begins at the level of the arterioles through to the level and terminates at the level of the venules. Then we said that the arterioles take on the nature of the arteries, and the venules take on the nature of the veins, which means when you compare these two anatomically, the arterioles have a narrower lumen and a thicker muscular wall. Comparatively, the venules have a larger lumen and a relatively thinner muscular wall. Then we said in between the arterioles and the venules are the capillaries, which now forms the capillary bed where all the exchanges take place. Gaseous exchange, nutritious exchange, exchange of waste products. It happens at the level of the capillary bed. However, between the capillaries and the arterioles, we found that there are another structure of a type of blood vessel which is referred to as the metarterioles. These metarterioles are surrounded by smooth muscle fibers which contract and relax. When they contract and relax, they control the amount of blood that flows through to the capillary bed. And so when the physiologic demand is normal, they will be allowing in a certain amount of blood. When the physiologic demand is high, then they will relax. And by relaxing, they allow in more or increased blood flow into the capillary bed. And that is why they are referred to as the precapillary sphincters, because they control how much blood enters their capillary bed. Now, looking at the capillary bed, you remember after talking about the structure, we also looked at what happens during an acute inflammatory response. Number one, remember what happens to the caliber of the blood vessels at that level. The vasoconstriction, the vasodilatation, the increased blood flow, which can be as up to 10 times. We call that active hyperemia. The hydrostatic and the oncotic pressures as the blood flows through the capillary bed. Initially, we have a higher hydrostatic pressure compared to the plasma oncotic pressure. That allows fluid to leave the blood vessel wall into the through the blood vessel wall into the tissue. As the blood continues to flow through the capillary bed, by the time it is terminating at the level of the venules, just before the veins begin, there the hydrostatic pressure has already dropped so much so that now the oncotic pressures are higher. And because of that, the fluid that had extravasated out of the blood vessel wall into the tissue is reabsorbed back into the blood vessel, and therefore there is no loss or increase. There is no formation of edema. However, we said that during an acute inflammatory response, the same thing will happen. However, because of the increased blood supply to the site of injury, as the blood flows through and fluid or water leaves the blood vessel wall into the tissue, yes, the hydrostatic pressure will be reducing as the blood flows along through the capillary bed. However, by the time it is reaching the end of the capillary bed, the hydrostatic pressures are usually still higher than the plasma oncotic pressures. At that point, therefore, you find that there isn't the back flow or back reabsorption of water into the blood vessel wall, and that is how edema ends up forming. We also looked at the cardinal signs of inflammation, and we mentioned them. Remember, there were 4. We had redness, we had increased local temperature, we had swelling, and we had pain. And then we made mention of a loss of function, and I told you some scholars will list it as a cardinal sign, others will not. And so it is a feature, but it may not necessarily be a cardinal sign. And so remember how we defined what a cardinal sign is, and then you will understand better. Having said that, we are going to look at the morphological features of acute inflammation today. And we are saying that whereas we understand that the nature of the inflammatory response or reaction is the same, it follows a similar pattern. There are variations in the macro and microscopic appearances of the various tissues in the body. So we are saying that whereas its nature is the same, and it is not dependent on what is causing it or the tissue involved. However, depending on the tissue structure, the macroscopic and microscopic appearances will not be the same, because all tissues are not the same also. So let us see. These variations will usually depend on several factors. Number one is the relative magnitude of the fluid formation, that is the exudate formation, and the amount of cellular elements, that is the white blood cells, entering the area that is inflamed. That is to say that if the causative agent for the inflammation is predominantly infective in nature, or it started off as from a different type of injury or cause of injury, but with time there could be superimposition of bacterial infection. In that case, the white blood cells will be abundant. There will be many at the site of inflammation. In that case, you are likely to end up with pus formation. When it comes to fluid formation, that is the exudate, this largely depends on the type of tissue. If it is a well compacted tissue, then there won't be much space for fluid to accumulate, and in that case the amount of exudate formation will be limited. However, if inflammation is happening in tissues that are loosely knit together, then it means there is provision for lots of formation of exudation, and that the more exudate forms, the more the pressure effects on the surrounding tissues and on the adjacent blood vessels. And remember, we said pressure at the site of inflammation can actually lead to ischemic injury to the tissue and further causing further damage. Having said that, the other variation is brought about by the nature and features of the organ that are inflamed. For example, if the organ like the liver, which is full of blood, is inflamed, then the lesions caused by active hyperemia and vasodilatation may not be readily visible, because already that particular organ is full of blood. So that particular feature may be masked. At the same time, a tissue like the lungs will usually allow lots of exudate formation and movement from one alveoli to another because of the nature of the organ, the way it is structured, and the communications. The third reason that leads to these variations is the degree of tissue damage that is produced by the injury which has caused the inflammation. That means the more severe the injury, the more severe the damage, the more acute and severe the inflammatory response will be. Now, further on, remember morphological features, whether we are looking at the macroscopic appearance or the microscopic appearance, these are functions of histology. And so the histological features of the various specific organs in the body during a disease process will be covered in clinical pathology. That should be next year. So carrying on, let us give some examples and see how these particular tissues will look like when there is an acute inflammation or when they are acutely inflamed. Number one, we look at the skin, and we are saying that, you see, the skin is the most superficial, most visible tissue or organ that we can see. Okay? And so it forms, whatever we see during mild inflammation of the skin forms the basis for the cardinal signs of inflammation. That means whatever you see on the skin is the same thing that is happening or appears on any other organ or tissue inside the body that we cannot be able to see. So if we are saying that the skin appears red, it also means that any other tissue that is inflamed will also appear red. If we say there is increased local temperature, because that is what we observe on the skin, it also means that any other tissue or organ that is inflamed, we also have increased local temperature. That is just a good thing for you to remember and make reference to. So, acute inflammation of the skin can either be mild or severe, depending on the degree of tissue damage or injury. In cases where it is more severe, then that means that even exudation will be more. And when there is exudate formation that is more, then that will lead to blister formation. Okay? The more the exudate formation is, the more likely you're likely to see blisters. For example, if you have ever worn shoes that are tight, that are pressing you on the toes or somewhere else on the foot, you will realize that after some time, blisters form around the area that you are feeling pain. That means that at that point, there was mechanical injury to your skin on your toe or foot. That led to an inflammatory response. And when there is an inflammatory response, we expect exudate formation. It is this exudation that you see as blisters. A similar example can be given when a patient or somebody sustains a burn. That inflammatory process on the skin leads to blistering. Those blisters are just because of exudate formation. Sometimes the injury may be severe enough so that there is loss of part of the dermis. When that happens, we call it an ulcer. And so we can easily define an ulcer as loss of continuity in an epithelial surface. And this can happen in any area where there is epithelial lining. And sometimes ulcerations can be or occur as a manifestation of chronic inflammation or in association with chronic inflammation. For example, patients who suffer peptic ulcer disease or ulcerative colitis are patients who have developed ulcerations because of chronic inflammation. Okay, so let us carry on. Hair follicles. Now, when hair follicles are inflamed, they may present with a boil or a furuncle. A very good example of a furuncle is on the beards. You can give an example of the beards. Young men or men who shave their hair, particularly the African hair, the Negroid hair, which is very highly coiled up. So when the shaving is done using a sharp object like a razor, and it is done against the flow of how the hair grows and aligns itself on the skin, that can cause infection and therefore inflammation of the hair follicle. What happens is that when the hair begins to regrow, because of its highly coiled nature, once it sprouts, it will coil, and when it coils, it digs into the epidermis. When it digs into the epidermis, it carries with it some of the normal flora on the skin or any other contaminating microorganism on the skin into the epidermis. And when that happens, an infection occurs and therefore inflammation takes place. And that is why you will see most men who will shave usually using a sharp object or a razor blade will usually develop furuncles. However, in other cases, you will see a boil. A boil is just now an accumulation of pus around the hair follicle. It is as a result of pus formation. The process of pus formation is also referred to as suppuration. Now, when suppuration forms and there is a lot of pus accumulating in a site, that collection of pus is known as an abscess. And so an abscess can be defined as a whitish or creamish yellow fluid that may or may not be blood stained and is usually viscous in nature. Okay. Let's look at the serous membranes. Now, the macroscopic appearances of the serous membranes is very different, slightly different from the appearance that we see on the skin. Examples of this tissues are the pleura, or the pleural tissue, the pericardial tissue. Pleural tissue lines the lung tissue, and we usually have, when you refer to your anatomy lessons, you will realize that we have the visceral pleura and the parietal pleura. The same thing happens with the pericardial linings. We have the visceral and the parietal, and then also the peritoneum. The difference is that these tissues are usually thin, shiny, and transparent. Therefore, when they are acutely inflamed, you quickly see the effect of vasodilatation. The blood vessels will quickly be seen, and because of the vasodilatation and hyperemia. So the surface appears red. Okay, it is very easy to see the blood vessels because of the vasodilatation and hyperemia. Remember, we said hyperemia is just because of the increased blood flow to the site of inflammation. After that, then there is fibrin deposition on the surface, and when this happens, then the area becomes dull. So the reason you see dullness is because of deposition of fibrin on the surface of the serous membrane. At the same time, of course, exudation will begin, but in the beginning there will be a very low cell count, and so when the cell count is very low or nil, we call it serous fluid. It begins to accumulate at the site where the inflammation is taking place, and where the inflammation is taking place will usually be the site of injury. Now, as this process continues, the surface that is inflamed, remember there is exudate formation, and I told you the covering, we have the visceral and the parietal. The parietal is the outer one, the visceral is the one next to the organ. In between there is accumulating the exudative fluid. There is deposition of fibrin on the surfaces. Okay, when this happens and the inflammation is still continuing, then the inflamed area will eventually be covered with an opaque creamy layer of fibrin. And when this happens, then the underlying structures now are not clearly visible, so we say that they are obscure. Now, as the exudate formation increases, and again, this depends on how much space is available. So, as the exudation continues to form, and the cells are now coming in. Remember, I told you the first white blood cell that appears at the site of injury in the first 24 hours are the neutrophils. So, as they continue to accumulate at the site of injury, then what was a serous fluid, we were seeing a serous fluid because of the low cell count. Now the cell count increases. These are pus cells, and so it becomes seropurulent because it is serous fluid mixed with pus fluid. Pus fluid is just the exudation mixed with white blood cells and other cell debris. So it now changes its name and becomes seropurulent. Anytime you see a purulent exudative material, understand it is because of the presence of white blood cells plus or minus other dead cells and tissue debris, and that is usually pus mixed with the other serous fluid. Then you understand that most likely there could be a bacterial infection. And remember also we said that different types of microorganism will tend to attract predominantly certain types of white blood cells. So if you see polymorphonuclear leukocytes, which are the reason why most of the times there will be pus, then you understand there could be, it could be because of a bacterial infection. Okay, so depending on the amount of exudate formation, if it is not much, then it is easily removed by the lymphatic drainage. And when this happens, then the parietal layer of the membrane and the visceral layers, they will usually stick together, and that is because of the fibrin deposition. So if the liquid is not much, the inflammatory exudate is not much, then it is removed by the lymphatics, the two layers will usually stick together because of the fibrin. And when that happens, and if the two layers are separated, then they appear rough and irregular. Actually, the description is what would look like if you applied butter on two slices of bread, put them together, and then separate them again. Whatever you'll see is like what appears between the two serous membranes when they are separated after they have been stuck together by the fibrin. So we call it bread and butter appearance. Now, having said that, then we want to take a look at some clinical examples so that it can also make sense to you and see what you've been experiencing as just what you're now learning. So we begin with the common cold. Now, the commonest cause of common cold is usually a virus. We call it the respiratory syncytial virus or the rhinovirus also. Very, very common. Another word for common cold is rhinitis. So what this virus does is that it gets, first of all, lodged in the upper airway around the nasal area, the nasal cavity, up to around the oropharynx or the nasopharynx, thereabout. It attaches itself to the mucous membrane, and then it multiplies. Once they multiply, remember, then that is when they are able to cause infection. While that happens, remember, the body realizes, something is happening. We are getting injured. We need to respond. We need to respond so that we can eliminate this thing that has come in and is causing us injury. We need to limit how much we are getting damaged. We need to continue functioning normally. Remember, those are the functions of inflammation. And so when the virus multiplies in the epithelial cells of the upper airway, then an inflammatory reaction will usually ensue. When that happens, the usual happenings of acute inflammation will usually take place. Number one, there will be the vasodilatation. When there is vasodilatation, then the mucous membrane appears red because of two things. Number one, the vasodilatation and the active hyperemia. There will also be exudate formation, and that will lead to swelling. Once that happens, then the patient begins to experience congestion and obstruction of the nasal airways. And that usually takes place in the early stages of a common cold. I'm sure all of us have experienced that. Now, during the process of viral multiplication, some of the epithelial cells may be killed. Okay? And this is usually sometimes followed by desquamation of the dead epithelial cells that have been killed. And when desquamation takes place, that produces ulceration. And then you start feeling a lot of pain. There's ulceration in your nostrils and all that. It is just because the viruses have multiplied. They have killed some of the cells, and once they're dead, they're now desquamating. That means they're breaking off. And once that happens, then they leave an open ulcer, and that becomes very painful. So, at the same time, anytime you have a mucus layer being inflamed, it will usually be accompanied by increased secretion of those cells. If in their nature, they are usually secretory cells. That means those cells which usually produce mucus will increase their mucus production. If it is in the bronchi, again where we find mucus, the secretion of mucus will also be increased. If it is around the eyes, again the lacrimal glands will produce more tears. So anytime there is inflammation of the mucus lining, then there will also be increased secretion. Now, in the case of common cold, there is an increased secretion of a thin mucus fluid because these cells usually produce mucus. So now that secretion will be increased, and then there will be an increased production of the thin mucus fluid. This mucus fluid will usually mix with the exudate that is forming as a result of the inflammatory process. And when these two touch the areas of desquamation, they produce, a patient really feels an irritation of the nasal lining. Why it is so irritating and painful is because now the mucus is formed, is mixing with this exudate, and then it is falling on the desquamated or the ulcerated surface of the mucous membrane. It is usually painful, and that is the reason sometimes when you have a common cold and you just bend a little like this, there's this effortless thin mucus. It's not exactly mucus, it's not exactly liquid that falls on or falls on your paper or on your table. That is just because of the inflammatory process. Now, with time and also depending on the circumstances and the environment, these areas of desquamation may undergo bacterial colonization, which we call also superimposed bacterial information. It is important at this point for me to mention that anytime there is a viral infection of the mucous membranes, that in itself predisposes that particular site to superimposed bacterial infection because of the desquamation. Viral infections act like the John the Baptist of the Bible. They come to clear the way and make it easy for bacteria to colonize and cause infection. So, if that happens, what started off as a viral infection now ends up as being also bacterial infection. And when that happens, then remember, initially I told you that anytime there is an inflammatory response, irrespective of the cause, initially in the first 24 hours, white blood cells, the neutrophils will come around. But then, depending, if there is now sustained bacterial infection, then more will come. Then they'll be accompanied by monocytes and others. Then when there are dead tissues and other tissue debris, then macrophages will also come. Okay? If it remains predominantly viral, then the white blood cells will still keep coming, but this time they'll be predominantly lymphocytes. So it's important to remember that. So if there is a bacterial superimposition, then there will be the likelihood of pus formation is increased, and in this case, first of all, the bacteria will make the inflammation worse. They will aggravate the inflammatory process, and also there will be now the purulent. Remember I told you pus purulent. The presence of pus when there is secretion and of any fluid, when it is mixed with pus cells, then it becomes purulent. Okay, so now you will have mucopurulent secretions. That is mucus mixed with pus. So we call it a mucopurulent secretion. So as time goes on and you're having this, patient is having this cold, you must have noticed even in your own experience that after that thin irritating secretion that was coming from the nose, after some time it changes and thickens, becomes yellowish or creamish yellowish in color. That means now you have more bacteria that have come onto play, and they're now trying to kill the causative agent and also remove the tissue debris and the desquamated mucus layers that were damaged by the viruses. With time, then the body will overcome the infection, and depending on the severity, then the clinician perhaps gave antibiotics, and eventually the infection is overcome. Once this is settled, then the inflammation now will begin to cease. because it is no longer required. The reason for which it was mounted has now been resolved. The areas of desquamation due to the viral injury are now begin to be restored back to normal. How does that happen? We shall learn more about that when we shall be covering wound healing. But in summary, it is usually due to multiplication, what we also call proliferation of the existing living cells. Now, different types of organs have different types of cells, but in this case, we are talking about the mucous membranes lining the upper airway, and so the proliferation of the existing cells that are alive will multiply and replace those that have been destroyed or lost. That process is referred to as healing. Now let's look at another type of inflammation. We call it pseudomembranous inflammation. This is a more severe and serious form of inflammation, as we shall see. Now, it usually follows injury to the mucous membrane. And this injury is usually so severe that it causes epithelial necrosis of the mucosal lining. And when this necrosis happens, then it will be mixed up with the fibrin deposition and so on and so forth and other cellular elements, and then it detaches from the surface. When it detaches from the surface, it causes a membrane, a pseudomembrane. It is not a true membrane. That is why it is referred to as pseudomembrane. So it forms a membrane, a pseudomembrane, which is consisting of the dead epithelial cells, the dead ones, the necrotic ones, mixed with the other cells and fibrin and all that, and then it detaches, and that pseudomembrane then can obstruct the entire airway. That becomes a medical emergency because it can cause respiratory embarrassment any moment. It is an emergency, a medical emergency. So remember, when there is, what do we call it? When there is the necrotic tissue detaches, remember it leaves a raw surface, which again is very painful, and it can lead to another superimposition of another bacterial infection. So this kind of severe inflammation of the mucous membranes, where there is a formation of the pseudomembrane, is referred to as pseudomembranous inflammation. Very good examples of this pseudomembranous inflammation are infection of the upper airway, that is the pharynx and the larynx, with an organism known as Corynebacterium diphtherium. This is the organism that causes diphtheria, which we usually immunize for in childhood. Another example is inflammation of the large bowel or the colon with a microorganism caused by a microorganism known as Clostridium difficile. Now, what happens, like I've already explained, is the extensive necrosis of the surface of the epithelium, and then accumulation of the other cells and the fibrin and all that comes into play when there is an acute inflammatory reaction, and then there is also acute inflammation of the underlying tissue. Remember, when this necrotic tissue detaches and leaves a raw surface, again, the inflammation process begins all over again around that surface, okay? While now the pseudomembrane is busy causing obstruction of the upper airway, the underlying tissue that has been laid naked, the ulcerative surface, again is getting inflamed, and so it becomes a cycle. So the fibrinogen in the inflammatory exudate will usually coagulate within the necrotic tissue. I think I've already mentioned that. Now, remember I also mentioned that there will also be the other white blood cells and other tissue debris that all conglomerate together, which is what forms the pseudomembrane. And then it covers the upper airway, the larynx, the pharynx, and that can easily cause respiratory embarrassment, and the patient can go into failure and arrest if nothing is done. Usually the membrane is grayish white or cream in color, and it is usually seen covering the upper air. Let's talk a little bit about other organs, and we shall start with the liver and the kidneys. Now, when the liver and the kidneys are mildly inflamed, the differences in how they appear when they are healthy and how they appear when they are acutely inflamed may not be much, because these organs, first of all, they are solid, they are neatly, the cells are tightly knit together. That means there isn't room to form much exudation. And then also they are blood filled. Their blood supply is very high and rich. And so even effects of vasodilatation and hyperemia are not very obvious to see with the naked eye. Okay? All right. However, when the acute inflammation is more severe, and when it is severe and then it is associated with large areas of necrotic tissue, that means that many cells are being killed, then there could be formation of pus. Because remember, the macrophages, all the phagocytes that we mentioned earlier, will all come in either to kill the virus that is causing the inflammation, or to kill the bacteria that is causing the inflammation, or to try and remove the dead cells or the other tissue debris. And so pus forms around those organs. And when this happens, then the macroscopic changes become much more obvious as compared to when we are talking about mild inflammation of those particular organs. Looking at the lungs, usually lungs are airy, very highly aerated organs, and there are lots of intertwining and interconnected alveoli. The air spaces are interconnected, so that presents a ready space for fluid accumulation when there is an acute inflammation of the lungs, which we call the pneumonia. Okay, so that means during inflammation of the lungs, which is pneumonia, there can be lots and lots of exudate formation and pus formation, and this can quickly just spread into the entire lung because of the interconnectivity of the airways. And this can easily happen without any sense of tissue pressure because of the large spacing. Now, going forward, in cases like those of lobar pneumonia, the alveoli in one lobe can fill with exudate and pus and inflammatory cells, but these can quickly be removed by the lymphatics. When the lymphatic systems remove this exudation, the exudate fluid and the pus, then the area is left looking pale. Then it solidifies. Remember, the lung tissue is spongy and highly aerated. It is not meant for fluid. It is meant for air. That is why lung tissue is light and it is poofy. It is spongy in nature. However, and when you learn your clinical methods, that is the reason why when you percuss over normal lung tissue, the percussion tone or note that you pick is resonant because of the underlying air-filled spaces. However, during inflammatory reaction or process, these aerated tissues become solidified. And when it becomes solidified is what we call consolidation. This consolidation, when clinically you percuss over an area of consolidation in the lung tissue, instead of getting the resonant percussion note, you get a dull percussion note. And in case there is also associated fluid accumulation, which is the exudate in the pleural cavity or within the lung tissue, and especially in the pleural cavity, then the dullness is even deeper and we call it stony dull. So remember those things when you are dealing with your patients. Just remember these simple things. They will help you in knowing what could be going on and interpreting your signs. Remember at the beginning we said that your practice of medicine will be as good as your understanding of pathology. And I should have said this at the beginning, that also if you understand inflammation very well, then you will be able to understand medicine also very well. That is not to say that other aspects of pathology aren't important, however, but we are saying that anytime there is tissue injury, irrespective of what is causing that injury, there will be an inflammatory response. There will be an inflammatory reaction. It doesn't matter what is causing it. It doesn't matter where it is taking place. It is the same. It is stereotyped. Therefore, if you can understand what happens in every tissue when it is inflamed, then at least some distance coverage in your understanding of medicine will be achieved. With those few remarks, I want to say thank you. Please, you're welcome to post your questions in the comment section. You can also send them to me directly to my email, or you can just write them down and we shall discuss them when we meet in class. Thank you and God bless you. Our main reference book is the Muyer's Textbook of Pathology by Harrington. And for further reading, I encourage you to also read the Textbook of Pathology by Hershey Mohan.